This conference will now be recorded.
Okay, so welcome to the class, all of you. So today, the most requested topic, the management of anti-cell antibody guideline. That is a GTG number 65. Then NTD guideline and brief of blood transfusion followed by questions. Okay. So first, I'll be just giving you a little, small information about the blood group system. Though it is not necessary to know about this for any of the exam, but for the better understanding. Okay, so blood group system. So like there are what the there are 25 blood group systems, like you can see it from here. No need to learn anything from here because nothing is going to come in the exam. It is just for an understanding. And every blood group has got a symbol and one letter or four letter, and they have apart from this, they have got some number of antigens. Okay, so these are 25 blood groups, like blood group systems. And you can see, we know our ABO most popular symbol is ABO. And there are for this there are four antigen. And similarly these kind of blood group systems are there, but most commonly we are looking for this ABO, RH, Kale, and Diego. But in the guideline this mention of this Diego is not there. And why we are interested in knowing this, because what can happen is this hemolytic disease of newborn. So we are worried about this. Okay, so this is about blood group system. Now RH or rhesus system is an example. In RH there are 45 antigens. Okay, that we know, that you can see it from here also. And it would cause more severe kind of hemolytic disease of newborn. Okay, so this is a little information about blood group system. Then usually RH blood group. So a little of genetics. Again, this is not necessary for your exam. So on the red cell membranes, there are certain, these proteins you can see. This is the RH protein. And for that, coding is done. And we know there is a coding system. And they're coding RH system coded in two adjacent gene, and they are on the chromosome number 1. Okay, they are on the chromosome number 1. So one gene will code for CC and big E, small e, and D polypeptide. Okay, and small d antigen is not identified. So if a person is D negative, so that means there would be no D antigen. Okay, this is little basics to know, but again it is not very important for your exam system. Now another system that we know is an ABO system. This A and B antigens, they are the oligosaccharide structures. They are present on the surface of the glycoproteins. The red cell membrane is made up of glycoproteins and glycolipids. And out of the glyco this A and B, these are the antigen, and the structure is oligosaccharide, and they are on the cell surface of glycoproteins. They are IgM, not IgG. Okay, sorry, antibody that would be formed against this antigen, that is anti-A antibody and anti-B antibody, these are IgM. And but very rarely it could be IgG. So mostly they are IgM. And from our basic knowledge of undergraduate days, we know that IgM is the big most largest side antibody, and it cannot cross placenta. Okay, because of that hemolysis will not occur. So ABO system is associated is very little and mild degree of hemolytic disease of newborn. Okay, usually happens when the mother is group is O negative. If the mother is O negative, the mother will have both kind of antibodies. And if the baby is either A, B or AB, then some mild antigen antibody reaction can happen even in the ABO system. This part, how the blood groups are formed, this I'm not reading it because that is not necessary for us as this stage. We know this. Okay, so a like this like this is blood group A, this is B, AB, and like this is O. So these are the phenotypes. Again, too much knowledge about this is not necessary. That is from our undergraduate days. Now, what is a necessary thing now? So what is usually a hemolytic fetal disease of newborn? So why we are so much worried about it? Actually, what happens if like the antibody is there in the mother's blood and baby has antigen, and if this antibody crosses placenta, so there would be antigen and antibody reaction in the fetus. Okay, because of that there would be destruction of red blood cells that would cause anemia. And now if the baby has any like if the fetus has anemia, what will happen? To compensate, there would be increased erythropoiesis, and usually it occurs in the extramedullary sites like liver and spleen. Okay, because of that there would be hepatosplenomegaly, and precursors, nucleated precursors or immature red cells will be released in the bloodstream. Okay, and if anytime FBS is done, then they will be able to know that. So what will happen now? The anemia is there, so there would be hypoxia. So fetal heart try to compensate it via increasing cardiac output. Because of that, there would be increased heart rate, dilated ventricle, and tricuspid regurgitation and cardiac dysfunction. Now, if the after that cardiac dysfunction, there would be development of hydrops, or like we already know that. So this further will tissue hypoxia because of anemia. There will be tissue hypoxia that will cause tissue damage and damage to myocardium, and also various damage to fetal endothelium that will cause increase in the capillary permeability. Because of that there would be accumulation that will lead to protein loss, and there would be like uh, like a protein loss from the intravascular compartment into third space. So because there would be a stage, this will cause stage of hypoproteinemia. Because of that there would be ascites, pleural effusion, pericardial effusion, skin edema, so all kind of edema, and that would lead to hydrops. So this is like knowledge about the pathogenesis of of hemolytic hemolytic like disease of newborn. Okay, so this like you guys a little knowledge, though we have done already we have already read this in our UG days. Now this was a little brief. Now I'll be just explaining this guideline, a little difficult, but I like sort of tried it making a little easy. So what the guideline says, that this antibody is usually detected in 1.2% of the pregnancies. Okay, maybe this number necessary for part 2 people. And like prevalence of clinically significant antibody is 0.4 only, so that much number of patients. And if the antibody screening is done, then the rate of positivity will be 1 in 80. That means if the 80 women are screened, one will have antibody. And with the prevalence of clinical significant, though the most common significant antibody will be anti-D only, but others could also be there, so that could be 1 in 300. And what is the most important cause for all allo immunization will be previous blood transfusion. So part 2 people may get this question, like what is the important cause for the all allo immunization, and answer will be like previous blood transfusion. Okay, now what really happens? So if the antibodies are already there, like if we do the antibody screening and the antibodies are already there, that means the allo immunization has occurred. And it could be maybe because of previous any kind of transfusion, maybe transplantation, or maybe because of the previous pregnancy. So there could be any root of it, it can happen. So this I have already explained. Because antibody it this anti-D antibody, this would be IgG, so they can pass through placenta, so they will affect if the antigen is there on the neonatal in the fetal red cells, so there would be antigen antibody reaction that would lead to this hemolytic disease of hemolytic disease of newborn, that pathogenesis I have already explained. Okay, so what could be the significant? So significant antibody that are at a risk of causing anemia. So that would be anti-D, anti-K, or anti-C. Okay, so this is from the guideline only, nothing new I'm speaking here. Now, what is the most common? So most common is anti-D. So from the era now these days, we give routine antenatal anti-D prophylaxis. But before that, like before that, in 18 to 27% of the cases, it was already it used to happen, this aluminization used to happen. So this also I have already explained, that ABO system can also cause a mild degree of hemolytic disease, but it will be very mild only, and it usually happens if the mother blood group is O. Because if the mother blood group is O, so mother will have both antibodies A and B, and if the baby is carrying like A or B antigen, then there would be reaction and there would be mild hemolysis. Because of that, every like whenever the any baby is born, though they are positive, mother is positive, baby is positive, but there is anemia. So this anemia can be explained by the sorry, not anemia, there is jaundice. So this jaundice can be explained by this, because mild to moderate degree of hemolysis can occur even in the positive also. And usually the mother will have O blood group, and baby will have any blood group with A and B. Okay, so this explains why the neonates, they have icterus or jaundice. Now, like what the guideline says, that if the significant antibodies are there, so patient should be explained implications for her and the baby, depending upon the type present. And usually these counseling should be done by the specialist, that will be the fetal medicine specialist. Okay, you can get question from this line also. Now, ART, what they say about the ART, there is no evidence that ART causes red cell immunization. But on the other side, what they say, if the if the donor egg is used for the mother, and mother has an antibody, then and a donor if the donor antigen we don't know, because that detail about donor will not be
Donor
there.
will not be
So in that particular situation, fetal genotyping would be required. Okay, someone's mic, if it is on, please off your mics. Now this is according to the guideline. So like antibody D may cause severe disease, and C severe disease, K will cause severe disease, and C and E together may cause severe disease in fetus and neonate. So the whole whole guideline is about all these antibodies, because though there are so many blood group systems, but the most common that would cause trouble will be this only. This table is from the guideline. Now, what we'll do and how we'll manage. So in antenatal, coming to the antenatal management. So in UK, whenever the patient, pregnant patient is coming, there would be always booking bloods are done. In booking bloods, they will do ABO and RSD typing and antibody screen. So this is like routine in UK. Now there would be possibility that there is no clinically significant antibodies there. So if there is no clinical and significant antibody, so we are happy. But they also assume that there could be possibility as the pregnancy grows, some antibody may come up. So they want to repeat this test at 28 weeks. If the 28 weeks again there is no antibody, so we are happy, no treatment is required. But if we are able to detect here, then we have to follow the antibody pathway that I would be explaining. Apart from for this also, let me explain how the things are done. So clinically significant antibodies, this I have already explained, same thing again. Clinically significant antibodies, like if they are there, then like blood uh, if we there are certain implications because of the hemolytic transfusion. So the booking, the testing will be done at booking, and tested will be repeated at 28 weeks of pregnancy. Now in when if you see this chart at 28 week, they are repeating it, like antibody and blood group both. Again, this arises a question why they are repeating blood group again, but there is no answer because the blood group would not change, only appearance of antibody can come. But if you have to like answer your SBAs, and if they ask you to like testing at 28 weeks, so you have to say about like an NTD and like blood group and antibody testing, both will be the answer, okay, because they are testing both again at the 28 weeks. And uh, in addition to the feed, so one risk of the clinically significant antibody, that baby can have that like a hemolytic the disease of newborn fetal anemia. Apart from this, there will be another trouble. If for any reason blood is required for the mother, then there would be so much of problem in cross matching, okay. So this I have showed you in the chart, that fetal anemia is greatest with D, C, and K. Okay, these other antibodies are also there, but the mainly it is caused by this. Okay, now this part we have already discussed. I'll speak it again, and it is also important because recently in the part 3 exam, this question about anti-C antibody has come, and then they ask about what could be the maternal and fetal implications of this. So this is the fetal implication. So this will answer your both part 2 and part 3 answer. So what could be the possible, what can happen? There could be fetal anemia, uh, like though it is a repetition of same thing. So previously I have discussed the pathogenesis. Now this would be the answer you will be speaking in the exam. So what could be the fetal effect of red cell antibodies? So your answer would be fetal anemia. There could be hyperbilirubinemia, bulimia, and like neonatal jaundice or icterus that occurs from the hemolysis or impaired erythropoiesis. If the severe fetal anemia, it can lead to hydrops, it can lead to preterm birth, or it can lead to perinatal death. Okay, apart from this, survival in this pregnancy, if the treatment is done, would be like 84%. Now, if the treatment is done and the fetus is non-hydropic, like less at early stage before the hydrop changes are there, then the survival will be 94%. But if the baby is like so much affected that the hydrops is already set in, then that time the survival will be 74, and overall survival if the treatment done will be 84. These numbers would be important for part 2 people. Now, anti-K antibody, if it is there, then it causes like all other antibodies. They were causing like antigen antibody reaction leading to hemolysis or destruction of the RBC. But anti-K causes anemia in a different manner. So it causes anemia like secondary to erythroid suppression. So, erythroid progenitor janitor cells that would cause starting up of the development of RBC, there would be suppression to that. So now RBC is not forming here. So anemia in NTK is because of not formation of the like uh, RBCs or the erythroid separation. Now here there is no destruction, so bilirubinemia will not occur. Okay, so this is important thing to know. In all other antibodies, this anemia is there because of the destruction. Because of that, we are finding that icterus also or jaundice. So the baby would require treatment. But NTK is causing anemia, but the way of causing anemia is different. So it is because of the suppression of erythroid. There would be no hyperbilirubinemia. So because there is no destruction going on. Okay, So this is important to understand. So now this becomes important for part 3 people, and part 2 as it is important because the direct question comes from here. Is it clear? Any questions? Okay, let me go ahead.
No questions.
Okay, now what to be done, like if the if the mother has antibody, so what will be our worry? Our worry is will be baby. So whether the baby has antigen or not. So if we find mother has antibody, second, what will be the next step? We want to know whether what the baby's antigen situation, baby has antigen or not. So uh, we can do fetal testing, or before that first there would be partner testing, or the paternal testing will be done. Because if the mother is negative and father also is negative, then there is no problem, baby will be negative only. But if the father is positive or father is heterozygous, then there could be possibility that baby would also be can be affected. So how we can detect whether the baby is affected or not? So there are two ways. So for antigen D, C, C, E and K, so DCEK, NIPT can be done. That is free fetal DNA. Okay, with that they'll be able to find whether the baby will have this antigen or not. Number one. So now, what is the accuracy for C? Because we are doing free fetal DNA, you must be knowing about this NIPT or free fetal DNA. This test is done from the maternal blood. Okay, so accuracy for C and E genotype, it would be 96 to 98%. Okay, but accuracy of genotype RHD, it will be like less than 95%. This number could be important for part 2 people. But NIPT test can be done for DCEK only, but there could be so many antigens. We already have shown you the table for other kind of antigen. If we want to know whether the baby has antigen or not, we have to do CVS or immunosynthesis. Okay, now this is a very important. So what will be the gestation, when NIPT can will with the NIPT will be able to detect this as antigens. So except for K, all other antigens can be detected from NIPT from 16 weeks of gestation onward. Only K is the, if mother has antibody K and we want to know whether the baby has K antigen or not, then NIPT has to be done from 20 weeks of pregnancy. The reason what the guideline gives, there could be possibility of false negative result if it is done early in the pregnancy. Though you might have read that NIPT test or free fetal detection from the maternal blood can be done from 10 weeks of pregnancy onwards. But NIPT is done for so many reasons, uh, to detect many other things also. But for the purpose of detecting this antigens, what the guidelines says that for C, E, DCE, it should be done after 16 weeks of pregnancy. For K, it should be done 20 weeks of pregnancy. Whole slide is important because part 2 people usually get question from this. And understanding for even part 3 also has become important, because as already told, the recent exam had a viva station from this guideline. Now, some question. So 34-year-old woman with antibodies and at 20 weeks of pregnancy. Now, she has been advised to go for immunosynthesis. So what do you think? What should be done? Immunosynthesis should not be done. NTD 250 to be given, NTD 500 to be given, or NTD not necessary. Anyone can give me answer. Any
Ma'am,
guess also?
anti-D not necessary, ma'am.
Yes, very good. Antibody not necessary. Why it is not necessary? Because the patient already has antibody. So that means uh, uh, allo immunization has already been occurred. So if mother is already positive for antibody, why the hell we want to give more? So we will not give antibody. So this is a catch, but many people will put the do the answer, 3, that saying 20 weeks 500. But if the antibody is there, that means patient is already immunized, so need not to give any antibody. So same is the explanation here. Invasive testing is not contraindicated if allo immunization has occurred. So here there is allo immunization, so it's fine. We can go ahead with invasive testing. All other person where the immunization has not been occurred, then antibody prophylaxis would be given. Okay, only this message I wanted to give you. Now again, you will get the question from here, fetal medicine unit. So referral to the fetal, what are the indications? Because you get answer question from this referrals also. So if the when you will refer to the fetal medicine unit, if the patient has a previous baby having unexplained jaundice, neonatal anemia, the baby required transfusion or any exchange transfusion. So in that, these are type of condition, if the previous baby is affected, that then the patient to be referred for the fetal medicine unit. Apart from this, any antibody except these three antibody DCK, any other antibody, if the titer is more than 32, if the titer is more than 32, then they are also at risk, so they are referred to the to the fetal medicine unit. So a little about the laboratory methods. DNC antibody, they are detecting by a kind of automated analyzer. For other antibody, they do double dilution test. So you will find that this tighter type of thing for the antibodies. Okay, so any other antibody except these and the titer is more than 32, referral to the fetal medicine unit is required because the baby is already at risk. Now again, this would be very important, full of questions for part 2 and 3. So like NTD, when if the NTD detection has been done, now they will do the quantification. I already told that it will be done with the analyzer. So then they will do testing. Now once it becomes more than 4 international unit, that time the patient to be referred to fetal medicine unit. Okay, now if the level is less than 4, and like if the level is more than 4 but less than 50, then the baby is at moderate risk of HDFN. This you get SBA from here. Okay, but once the level of entity is more than 15, it causes severe HDFN. So every part is important. Okay, and for part 2 and part 3, because in part 3 also they would give you antibody, and also they would give you a designated range of it, and you have to find out from your station that what is the value and which category you will put the patient in. Okay, so anti-C, again the values are different. Once the anti-C levels are more than 7.5 international unit per ml, refer to FMU. Anti-C like more than 7.5 and less than 20 correlates the moderate risk, and more anti-C more than 20 will correlates with the high risk of HDFN. Okay, and like these are the titers. Sorry, these as I already told that DNC, they are doing like uh, they check it by the automated analyzer. For others, they are doing double dilution titration. Now NTK, so the moment NTK is detected, we are referring. The reason I have already explained, because NTK usually causes that erythroid suppression. So fetal anemia would be severe. Even the titer is very small, because as they are suppressing the source, so there would be severe fetal anemia. So we have to be more careful. anti-E, if it is there along with anti-C, if C and E are there, then severity will be more because of the two antibodies. Then referral will be done at even the lower level indicated. Okay, so C and E together, then the patient would be referred at the lower levels also. So this part is very, very important for both part 2 and part 3 people. So this we know that less than 4 SDF and unlikely, 4 to 15 is moderate risk, more than 50 is high risk, and high risk of high drops. Okay, high risk of high drops. Now, what we'll do if we are able to detect antibodies D and C, anti-D and anti-C, what we'll do? We have to repeat that titer every 4 weeks till 28 weeks of pregnancy. Then later on, it will be increased 2 weekly until delivery. But anti-K will not correlate with the development and severity of anemia because of the arthroid separation, but still measurement to be done every 4 weekly till 28 weeks and every 2 weekly until delivery. For other antibodies, they would be retesting at 28 weeks, because if they are able to detect anything at 28 weeks, then referral to the fetal medicine unit will be done. So what usually they do at the fetal medicine unit? So why we are worried? We are worried for only one thing, that is fetal anemia. And how we can detect fetal anemia? By doing middle cerebral artery Doppler. So usually at the middle cerebral artery Doppler, they check the peak PSV, that is the peak systolic velocities. Usually, if at a certain level, as we already read, at the certain level, if the antibodies are there, they will be the risk because of the risk of anemia. They will go to the fetal medicine unit, and the monitoring, women will be called 1 to 2 weekly. Why? Because they will do MCA PSV. Now with this they are able to detect it early, and if they are able to detect it early, then appropriate like treatment in form of intrauterine transfusion can be done. Okay, now other signs could be polyhydramnios, edema, and cardiomegaly that I have already explained. Now this question also comes. So MCA PSV has got a predictive value of 100%. Sensitivity is 100, and it do have a false positive rate of 12%. This question I have seen, so these numbers are important. Okay, now how the interpretation is done. Usually, if the MCA PSV is more than 1.5 MOM or modes of median, then there could be possibility of anemia. In that situation, fetal blood sampling would be done, and also intrauterine transfusion will be done to counteract with the or to treat the fetal anemia. But another thing, the sensitivity of this monitoring by the MCA Doppler would decrease after 36 weeks of pregnancy. And if the FBS is done, then chances of fetal loss is 1 to 3%. And if the baby is hydropic, it would be more. Now this part I have already explained. So whenever the treatment is done, patient to be explained whether she wants to go with the intrauterine transfusion, then benefit and risk to be explained. But or otherwise, what will happen is hydros, preterm, death, jaundice, kernicterus, and the possibility of neonatal exchange transfusion. So all this thing has to be explained to mother. Okay, so Saujanya, you have asked a question. So once we are able to, as I already told, at the antenatal visit, they will do the antibody check. If they are able to find any significant antibody, Then they will do that, they will detect what type of antibody and what are the titers till it is less than 4. Monitoring will be like done 4 weekly and 2 weekly, and once the titer becomes more than 4 for NTD, it will be referred to the fetal medicine unit, so that they will do MCA PCV. And once how we will know allo immunization has occurred, the moment we are able to detect NTD antibody in the maternal blood, that time we will say that allo immunization has occurred. Hope I have answered your question. Now, what could be the implications for like mother? So mother, the problem will happen that whenever the blood, if the any blood is required in case of APH, PPH or whatever, then cross matching will take a lot of time, and obtaining relevant blood will take longer time. And also they want that they should do the cross match if woman is more at risk. So cross match of sample should be done every week. If the patient has anti-cell antibodies, then and the patient is at risk, then they according to guideline they should be cross match sample taken at every week. They are checking it again because they want to know the antibody, like if any new is coming or what are the titers. Then again what they say that what is the what, like what are the implications if the maternal transfusion is required. So what they want, when the we have to transfuse blood to mother, so it should be of same ABO group and it would be of same RHD typing, and it should be K negative and CMV negative. Like this would be the ideal combination. Like this question also comes many times, people have sent me this question. So what type of blood to be given to the mother? So ideally it will be matched with ABO grouping, RH typing, K negative and CMV negative. Okay. So and if the patient has got a negative blood group and antibodies are not there, then we give prophylaxis and we give NTD at the sensitizing events that I'll be just speaking in details when I speak the NTD guideline. But again, Sojanya, this line you were asking, so if the antibody is already detected, that means mother is already immunized or mother has got immunization. Then prophylaxis. Why to give prophylaxis then? Because it is already there. So no prophylaxis is required. Okay. Now fetal transfusion. I just put it because it is a part of the guideline. But again, I have not seen question from here. So if they are doing intrauterine transfusion, like if MCA PSV it detects fetal anemia, then patient would be counseled. The treatment is fetal transfusion. So what should be the red cell preparation for IUT or intrauterine transfusion? Group O or ABO identical to the fetus, because we are taking like a sample for the fetal blood sample when we are doing intrauterine transfusion. So first they will take fetal sample and they will try to detect the blood group. Okay. So either it will be, so if we know the fetal blood group, then for IUT we'll take the blood that is ABO identical to the fetus if we know it. But if we don't know it, then it is group O. It should be negative to the all antigens whether the mother has antibodies, whatever kind of antibody C, D, K. If the mother has antibody, that antigen should not be there. Okay. Because we know there would be reaction. It should be K negative. It should be less than 5 days old, and for fetal transfusion, and it should be CMV seronegative, and it is irradiated transfused within 24 hours of irradiation, and the hematocrit will be zero point 0.7 to 0.8. So like, though I have not seen a question, but part 2 people may get anything from here. So these are the requirements if the intrauterine fetal transfusion is done. Now what are the route of fetal transfusion? Either it is not in the guideline, but yeah, I just want to give complete knowledge about the topic. So either it will be umbilical vein at the point of cord insertion, or it will be into the intrahepatic vein, or it will be into the peritoneal cavity. But if it is in the peritoneal cavity, it will not be as effective because some of the blood will be absorbed and or into the fetal heart. So these are the routes of the fetal transfusion. So once the decision is made and the fetal is anemic, then invasive procedure, first we have to take the sample again for the blood group and to confirm anemia, and the same single puncture, like single puncture blood transfusion is done. That is understandable that we will not do two punctures. Now intrauterine is done. Now the baby has come out, the delivery is there. After that we did if the neonate has anemia and we have to give blood, then these are the requirements according to the guidelines. So it should be ABO compatible with mother and baby both. Okay, mother and baby both. Now here it is easy to calculate ABO grouping blood group of the baby because the baby is born. So it should be ABO compatible with mom and baby, D negative, R either it would be RSD negative or RSD identical to the neonate, because this time we'll know that what is the RS typing for the baby. It should be K negative. It should be negative for the antigen that mother had antibody. Again, to avoid that antigen and antibody reaction, it should be less than 5 days old, CMV negative irradiated, and hematocrit will be 0.5 to 0.6. Again, I have not seen any question from here, but yes, you guys should have a little knowledge about it. If any SBA comes, you'll be able to answer. Now sometime a small, okay, this is for the exchange transfusion if the icterus is there. So if the icterus is there, usually the blood will be taken from baby and the transfusion of blood will be done. So that is the exchange transfusion or neonatal exchange. So these are the requirement for exchange, and these are the requirement for top up transfusion for fetal anemia. So these things are same. The thing is different that it should not be irradiated unless previous IUT is there. Apart from this, it could be like 35 days old. Here it was it should be less than 5 days old, and the hematocrit for exchange was 0.5 to 0.6, and for top up transfusion here it can be up to 35 days old. Okay, and so these are few things that you can read through, go through it, though it is quite similar, only small differences are there, and the question I have never seen, but yeah, part 2 people can get some question. And now there would be another scenario that the baby has got IUT, then when the IUT intrauterine transfusion is given, so usually the blood will be irradiated. So now again, if the baby requires blood, then blood has to be irradiated, otherwise there will be transfusion associated graft versus host reactions. Okay, so if the intrauterine transfusion has been done, then the blood should be irradiated. Okay, now what they say, if the emergency is there and in case of emergencies blood is required and we don't have blood, then we have to balance whether the patient will keep on bleeding or whether we'll give blood without knowing ABO and RST, that will cause hemolytic reaction. So we have to kind of balance risk of hemorrhage or patient losing life or risk of hemolytic reaction. But yes, we know that O negative blood can be given. Transfusion should not be delayed if the life threatening hemorrhage is there in the, but if ABO RSD K compatible blood is not matched and other blood has been used, then this is the you have to, this should be done. So IV methylprednisolone 1 gram, and patient has to be monitored because there could be possibility of transfusion reactions. If the IV methylprednisolone 1 gram and monitoring closely. If the patient develops severe reaction, then patient will require full resuscitative measures, including use of adrenaline. And the presence of antibodies has no implication for other blood products such as platelets, FFP, cryoprecipitates, and fractionated blood products. So you may get question from here that patient has been given unmatched blood. What should be done? So this would be the answer, like methylprednisolone 1 gram and monitor closely. And if they say that patient develops some reaction, then your answer will be full resuscitative measures, including use of adrenaline. So this is again from the guideline, can come in the question, so you should know. Now, what will be the implications for intrapartum? Usually, if NTD is there, and then timing of delivery will depend on the red cell antibody and the fetal anemia or fetal therapy. So this would be sort of a deciding factor for delivery. Apart from this, like what they want, that if the anti-red cell antibodies is there, that can cause fetal anemia, and but the stable pregnancy is there, then usually they want the patient to get delivered by 37 and uh, in between 37 and 38 weeks of pregnancy, and there should be continuous fetal monitoring during the labor, because we already know that baby is at the risk of anemia. So this too much intrapartum management, it is not given in the guideline, only this much. Now baby is born, then yeah, you will get question from this also. Even it was asked in the exam as well, that what are the investigations you are going to do. So investigation will be direct antiglobulin test, and hemoglobin, bilirubin levels, and ABRH for the baby, for the neonate. If the DAT test is positive, that means that infants' red blood cells are coated with antibody, but they're not that they cannot predict the severity of hemolysis. And hemoglobin is important because we have to know whether the baby is having anemia and the baby requires blood transfusion. And bilirubin for the management of connectors or jaundice. So these are the tests. So this can come in part 2 exam, and part 3 it has already come. Neonatal management is also important, has been asked already as a question. So what is a neonatal management? There should be regular assessment for neurobehavioral status, and because there will be development of jaundice and anemia. Why neurobehavioral status? Because there would be, if the jaundice is there, then it can cross the that barrier, and it can reach to the baby's brain, and baby can show some neurobehavioral behavior symptoms. Therefore, regular assessment has to be there, and the regular monitoring for bilirubin and hemoglobin to be done. A patient should not be early discharged. Mother should be encouraged to breastfeed the baby to avoid dehydration to the baby, because if the dehydration is there, then there would be increased severity of jaundice. If the bilirubin levels are rising rapidly, or they are above the interventional threshold level, then consideration for either phototherapy or exchange transfusion may be required. Apart from this, like exchange transfusion, uh, why we are doing that? Because with the exchange transfusion, as I already told you, what they will do, they will remove the blood from the baby, and they will like transfuse the blood from outside. So, and what are the requirements of blood for the exchange transfusion, I have already discussed. So what is the main aim of exchange transfusion? Our aim is to remove red cell that is coated with antibody, and also excess of bilirubin, because if we already know, if the excess of bilirubin is there, then it is going to affect baby's brain. So because of that, we are doing exchange transfusion. So this is a neonatal management, and the question has been asked in part 2 and part 3 exam. Now, what could be the implication for the future pregnancy? A woman with a history of a baby affected by HDFN. So, like in future pregnancy, there should be early assessment and referral to the FMU, that I have already explained previously. Now, what could be the long-term complications that can happen if the anti-cell antibodies are there? Some infant may have anemia that may persist for a few weeks following birth, or some may have late anemia that happens because of the hyporegenerative anemia. So this could be the long-term consequences that can happen. So like I have explained kind of this guideline. Now I'll just give you the summary, though now the things become easy. So at booking bloods, as I already told, that we are doing this like ABO grouping and RH typing, and also antibodies. If at booking we find that there is no significant antibodies, then a repeat test would be done at 28 weeks. If the 28 weeks we find that again there is no body antibody, so we are happy. So we are happy like because no further action is required. But if we find significant antibodies, then what we'll do? Now another situation that like we find we have done the booking bloods. On the booking bloods we find antibodies that are significant, but these are not DCK. Then in that situation, paternal and fetal genotyping to be done for the corresponding antigen, and antibodies and antibody screen would be repeated at 28 weeks. So this we already know that if we detect some like antibodies, um, or insignificant antibodies, other than DCK consideration for this, we want to know about the father, so paternal testing and fetal genotype, and again antibody screen will be done at 28 weeks. Now this also, if the clinically significant antibodies are there, so and if they are DCK, then we are doing 4 weekly test or monthly test at till 28. From 28 weeks onward we are doing weekly test, and when the baby is born we are doing anti-globulin test like DAT test, that is a direct Coombs test, or anti-globulin test, hemoglobin, bilirubin, and the baby typing, RH typing. Okay, so uh, now like this is a summary for anti-D antibodies. If we are able to, so this is the whole summary. If the patient is we have done the antibody testing and we find that the patient has anti-D antibodies, then what will be the next step? We do the quantification. That means we have to find the number, how much the quantification of antibody. Now if it is 4 and in between 4 and 15, we know she's at moderate risk of HDFN, and more than 15 it is she's at severe risk. So once we detect it is more than 4, then again we are referring to the fetal medicine unit. So what will be the job? So we first of all we want to know whether the what is the status of the father. If the father, there could be two possibilities. Father could be D positive, homozygous or heterozygous. If the father is homozygous, that means baby would be at risk. Father is homozygous, that means the baby will be at risk. In that situation, like monitoring will be done, and referral to the fetal medicine unit will be done, delivery by 37-38 weeks, and the cord bloods. But there could be another possibility that father is heterozygous. If the father is heterozygous, that means in that situation there could be possibility baby may be baby may have baby may be positive or baby may be negative. So we have to consider doing baby testing, and baby testing will be done with the free fetal DNA. Now come here. So here NIPT we are doing free fetal DNA. So if the baby is positive, then again the same pathway. But if we find NIPT we are doing, and we find that baby is D negative, then we are not worried. So now you can see it from here. If we have first, we'll do the test for father. If the father is negative, so we are happy that there is no risk of HFD HDFN. And if we have if baby testing has been done and free fetal DNA, again the baby is found to be negative, then also baby has not risk, so nothing will be done in these two conditions. Other condition, whether the baby is positive or a father is heterozygous, in these two conditions, like baby would be at risk, so whole pathway would be followed. Is it clear? Because most of your questions will be solved by this only. Is it clear? Is it clear? Okay. Now we move to the anti-C antibodies. Again, everything is almost same except this titer. So we detect when the booking bloods, we are doing anti-C antibodies. We find it positive. Then we do quantification. On the quantification, if it is like less than 7.5, if it is 7.5, then we are referring to FMU. The patient having quantification between 7.5 to 20, baby has a risk of moderate SDFN. If it is more than 20, baby has at a severe risk. Okay. Now, what will be our job? So, if the mother has anti-C antibody, so first we want to know about the father. Okay, we want to know about the father, whether the father is positive or not. If the father is homozygous, then baby has that risk. So, this same pathway. If the father is heterozygous, then there could be possibility baby may be effective, baby may not be effective. Then to know the baby, we are doing NIPT, and if we do NIPT and we find the baby C positive, then same pathway. If the baby is C negative, okay, by FFDNA, or if we do father testing and father is C negative, then there would be no risk. Okay, so father C negative, baby FFDN negative, in that situation there is no risk. Okay, because and baby now, if the mother has antibody, that doesn't make any sense, because baby has no antigen. So baby has no antigen, so antibody reaction, hemolysis, HDFN cannot happen. Okay, so this is sum up about anti-C antibodies. And about this anti-C antibody, the question appeared in the part 3. Now coming to the anti-K antibodies, again the same thing. Here I already told you that in anti-K antibodies, they are doing titration by double dilution method, so that number is not there, because there is no, and they're not doing that automatic analyzer test. So now if the like they will do the titer, they titer the level, but what next step they will do, they will check for the father. If father is homozygous, baby is at risk, then they'll do the if the father is heterozygous, 50% baby will be affected, 50% baby will not be affected. So they will do NIPT to know the K. If the baby has got K, so baby is again at risk, same pathway. If the baby is K negative, then there is no risk. So again same, if the father is K negative, and if the baby is by FFDNA, we find baby is K negative, then we are happy. If the mother has antibody, then it is not going to affect our baby at all. So this is a sum up of anti-K antibody. So that's all I have to say about this anti-red cell antibody. So before I move to anti-D guideline, any one of you have got any question? Okay, fine. So, yeah, so now that was an important guideline, and a little tough also. So I got request for that, but yeah, we have to complete all topics. So I put the other guidelines of the same topic. Now this is again very important, NTD guideline. Again, NTD guideline, it will not take that much of time. So we have to identify, usually if the mother is anti-D negative, like if mother has got blood group negative, RH negative, mother is RH negative, then in that particular situation, we have to give baby mother prophylaxis if the potentially sensitizing events are there. So these are the potentially sensitizing events. Okay, these are aminocentesis, CVS, chordosynthesis, APH, external cephalic version, abdominal trauma, sharp blunt, open closed, ectopic pregnancy, evacuation of mole, IUD, stillbirth, intrauterine therapeutic interventions such as like transfusion, surgery, insertion of stent or laser. Apart from this, miscarriage, threatened miscarriage, therapeutic termination of pregnancy, and delivery, instrumental, normal, cesarean, and intraoperative cell salvage. So these are the potentially sensitizing like events. Okay, so you will get a scenario and you have to find out that whether you have to give NTD or not. Then according to the number of weeks, so if it is less than 12 weeks, what are the conditions where we are not giving NTD? Number one, if there had been complete spontaneous miscarriage less than 12 weeks, and there had been no instrumentation, then NTD is not required. You will get question from these two lines. So spontaneous complete miscarriage less than 12 weeks without any instrumentation, if it is happening, then no NTD. Again, if the patient has threatened miscarriage but bleeding stops, there would be slight bleeding and it is stopping, then this is also the condition. NTD prophylaxis is not required. So this you have to know. You will get question from here. Now, the few things I had to say, this is from the ectopic guideline. Why I have put this slide here? Like, according to the ectopic, nice and miscarriage, what an NTD is not required in these conditions: threatened miscarriage, complete miscarriage, PUL, medical management of ectopic and miscarriage. Now, if we go to NTD guideline, ectopic pregnancy, regardless of management, and miscarriage, regardless of management, they are considering them potentially sensitizing events, and they according to this NTD guideline, the NTD would be required. But if we go to this ectopic pregnancy guideline, if the ectopic pregnancy or miscarriage managed medically, they are saying no to NTD. Again, yeah, this is a little controversial thing. Now, if you ask me from where to answer, again, it would be a difficult situation. But the ectopic guideline has come in 2019 and entered in 2014. So in my opinion, answer will come from more new guideline, that is ectopic pregnancy. So this thing is this thing is different in both of the guidelines. Okay, in my opinion, answer should come from ectopic. Because of this causes confusion and the people send me request for that. So because of that, I want to clear that, so I put this slide here. Okay, now less than 20 weeks NTD, what are the events we are giving NTD? What is the dose of NTD? Will be 250 units. And less than 12 weeks, feto test for feto maternal hemorrhage is not required. So these are the events, okay, where we will give NTD: ectopic, molar, therapeutic termination, and uterine bleeding if it is repeated heavy associated with abdominal pain. Okay, you may find any question from here, any scenario, any part 2 or part 3 people will get it. And for the part 3 people, even saying one line, you get marks on your safety or applied knowledge domain. Now, if there is a continual bleeding occur, a patient is pregnant and the bleeding is continuously occurring, and she is in between 12 to 20 weeks of pregnancy, then in that situation, NTD dose is 250. You have to give at 6 weekly interval, but the test for FMH is not required. So the take home message: less than 20 week FMH test is not done. Okay, but if another kind of scenario, patient has a continued bleeding, but the patient is after 20 weeks of pregnancy, in that particular situation, after 20 weeks the dose increased to 500. Okay, you can see it. If any patient is bleeding again and again after 20 weeks of pregnancy, the guideline recommends 500 NTD has to be given 6 weekly. Okay, but FMH will be done 2 weekly. So this is important to know. So I'm repeating it again. If the bleeding is there in between 12 to 20 weeks of pregnancy, the dose of NTD is 250. and at the interval of 6 weeks, and FMH testing not required. But if the bleeding occurs after 20 weeks of pregnancy, then dose is like 500 6 weekly and FMH done 2 weekly. So this part is important to understand because you may find question from here. Now this is the summary. So potentially sensitizing events, if it is less than 20 weeks, then NTD dose we are giving 250 and no FMH. So before we give NTD to any woman, we have to always confirm the woman identity, and we have to confirm the RH negative. We have to know whether the patient has ever received previous NTD or not. We have to take informed consent. Then if the gestation less than 12 weeks, then 250 units usually given within 72 hours of the event. Before you give NTD, confirmation of product, dose, expiry date, and the patient ID has to be like noted down. Okay, 12 to 20 weeks, again the dose is same. So less than 20 weeks, 250 dose and no FMH is required. Now, potentially sensitizing event after 20 weeks of pregnancy. So this I have already explained. So dose will be 500 and FMH testing would be required. So this part is the same. So I would not repeat it again. So whatever the sensitizing event is there, so 500 international unit of NTD to be given within 72 hours after all confirmations that I have already told. And if the patient is bleeding to every bleeding continuously, like off and on, then 6 weekly we are giving NTD and 2 weekly we are doing FMH test. Okay, if why we are doing FMH test? Because we have to know whether we require to give her more NTD. So this is after 20 weeks of pregnancy. Now dose calculation, you will get question from there. So 125 international unit, the mode of administration is IM, then this will cause neutralization of 1 ml of fetal red blood cell. If we are giving IV, then it is less dose. 100 international unit of NTD would be required for clearance of 1 ml of fetal red blood cells. And what will be the site of injection? It is deltoid muscle, and the that is considered to be appropriate and safe site. Okay, you will get question from here. Now this is again a very important thing, routine NTD okay, NTD prophylaxis. So usually before we offer this, 28 blood group and antibody screen is done, that I just told you in a previous guideline. So usually this routine antenatal prophylaxis, it is done at 28 weeks. Before that, first part will be to take sample for blood group and antibody screen. Okay, after that there are two regimes are there. So there could be two dose regime. In two dose regime, 500 international unit of NTD given at 28 weeks and 500 will be given at 34 weeks. What is the second regime? In second regime, single dose, 1500 international unit is given anywhere in between 28 to 34 weeks of pregnancy. Now, if we look at the patient compliance, we already know. Usually, considering giving single dose would be more cost effective, because we understand that the patient don't want to come 2 times. So single dose regime would be cost effective. Now, if this is again important to know, if a patient has any sensitizing event, what we have discussed in the table, and the patient received NTD, then regardless of that NTD administration, antenatal NTD prophylaxis would be done only. So regardless of any event or previous NTD, and NTD prophylaxis, routine antenatal NTD prophylaxis would be given. You get question from this line. Now this is the same thing that I have spoken about, like this routine antenatal NTD prophylaxis. So either it will be like single dose. First they would be checked for blood group and NTD screen. Then administration will be done 1500 single dose, 28 to 30 weeks. Okay, so it is 30 weeks. Okay, or it will be one two, if the two dose receive, one dose will be at 20 weeks, second dose at will be at 34 weeks. Okay, now again, before sometimes there would be a confusion whether the patient is sensitive to NTD or not, because if patient would have if the patient have received NTD for any other reason, then small amount of NTD will come positive. So in that situation, um, like if there is no clear conclusion, then it should be assumed that it is in passive NTD. Okay, and if we NTD has to be given if the blood group of the patient, RH typing of the patient is not confirmed, then patient to be treated as negative unless confirmation is done. And then FMH test is usually done to detect fetal cell in the maternal circulation, because whatever the NTD we are offering, if they are not able to neutralize, then additional dose would be given. Okay, now if the usually we in the prophylaxis we are giving 500 international unit, and we that is usually given IM, and 1 ml of IM will neutralize 125 international unit will neutralize 1 ml. So giving 500 international unit, we think usually 4 ml of the fetal that fetal blood would be neutralized. But if it is more than 4 ml, then we have to give more doses. And now so we have to do follow-up test for FMH testing. Now, if the patient has received NTD IV dose, then the test to be done after 48 hours to find out whether more dose of NTD is required. But if the test has been, if the patient received NTD injection IM, then usually to check whether the cells are cleared or not, the sampling to be done after giving NTD 72 hours if the IM dose is given. Okay, so this is like follow-up sample to find out whether the complete clearance has been done or not, because that much time the it will fetal cells will be required to get clear off from the maternal circulation. Now postpartum, again that we already know, postpartum baby testing will be done. If the baby is positive, then 500 international unit of NTD would be given within 72 hours of delivery, and the test will also be done for FMH. Why? Because we have to find out whether additional dose is required or not. So this is about postnatal. Now again, this is the same thing. So that usually now they are to detect whether the more than 4 ml of FMH there or not, and the NTD has been given. So if the IV NTD is given, so follow-up test is done within 48 hours, and if the IM dose is given, then the test to know the clearance of fetal cells will be done at about 72 hours. Okay, and so this I have already explained. So they will do this test, and they find that still the fetal cells are there, then they will consider giving additional dose. Now this question you find in the exam, it is necessary for both for part 2 and 3. Now if the intrauterine death is there, then in the intrauterine death fetal sample cannot be there, and intrauterine death itself is a sensitizing event. So whenever you see a patient with fetal death and patient is negative, in that situation that should be considered as a sensitizing event, and within 72 hours usually 500 international unit of NTD to be given. And once the delivery is done, then FM test the ones, and the maternal sample will also be taken for FMH. And if that detects if the FMH test shows that fetal blood cells still there, then additional dose can be given. And once the patient is delivered, then again after delivery, whatever the prophylaxis is given will be given only. So the message here is that if the usually if the antenatal patient, patient with a live birth, when the patient comes for delivery, we give postnatal prophylaxis. Okay, but if the patient is come and the IUD is there, so IUD itself would be insensitizing event. So we consider giving NTD within 72 hours and also testing for FMH, and whatever will be the delivery thing will be done after delivery. So this is the same thing, diagnosis of IUD in sensitizing event rather than delivery. So delivery management will be the postnatal thing, but diagnosis of IUD being in sensitizing event, so NTD to be given, and the blood should also be taken for maternal blood to be taken for FMH testing. This is again the same thing. Now see, if the IUD is there, then the 500 FMH test is done, and 500 international units to be given within 72 hours of delivery. FMH, sorry, it is less than 20 weeks. So less than 20 weeks you will give, no, it is more than 20 weeks at delivery or on diagnosis of IUD. So if it is if the patient has an intrauterine death and it is like more than 20 weeks, if it is more than 20 weeks, so it should be considered as a sensitizing event. So you will give a 500 international unit immediately within 72 hours of delivery, and you will do FMH test. Once the delivery is there, then whatever the dosing or whatever we do, that will be doing later on. So the message is that intrauterine death is an is an sensitizing event. So take it as a sensitizing event and give NTD prophylaxis. Now, if the intraoperative cell salvage has been done during cesarean section, then in that situation, large amount of NTD is given. So it will be given 1500 international unit, and a maternal sample to be taken for FMH within 30 to 45 minutes. Okay, and you will find this question from here in the exam. So this is like, you can just see the fetal cell salvage is going on. In what is usually done, the patient, if they are like Jehovah's Witness, they will not accept blood products. In that situation, blood is taken from the patient body, then all that washing, filtration, whatever is done, then it is retransfused. So it is also, so this is a cell saver machine. It is also called as an autologous transfusion. In that situation, there could be possibility of that contamination or whatever. So so high dose would be required. So minimum dose they are giving 1500 international unit. But to find out whether more amount is required, they are doing maternal sample testing within 30 to 45 minutes of FMH. Okay, and once we have given NTD, that I already told you, and if the IM is given, so we are doing testing again after 72 hours to know whether we require more NTD, and if the dose has been given IV, then we do follow-up testing for FMH after 48 hours to know whether the more NTD is required or not. Okay, so yeah, in the platelet transfusion, so dose of if the 250 if this what the your guideline says, if the five therapeutic doses of positive platelets has been given within 6 weeks period, then dose of 250 international NTD is required. Okay, and then the platelet transfusion is done. It has to be group compatible. And if the patient has got low platelet count, okay, and you have to give NTD, then we know that if the patient has thrombocytopenia, usually IM injections are avoided because there could be hematoma. So either the NTD would be given subcutaneously, or IV preparation to be given, okay. But if the patient is has got no childbearing potential, that time NTD is not required, because whatever NTD we are giving for the mother patient of childbearing age, because we don't want baby to have any hemolysis or hemolytic disease of newborn. So you will get question from here also, that in the platelet transfusion NTD is required. Okay, and this is, you will find question from here also. No NTD prophylaxis is required if RH negative woman receives RH positive FFP or cryoprecipitate. So in FFP and cryoprecipitate, if it is given, then NTD prophylaxis is not required. So any question till now? Any question from now?
Doctor, how to differentiate between the antibody related to the that prophylactic antibody given, or antibody related to the sensitization?
So the,
No.
if it is okay, I got it. You want to know whether it is a antibodies detected because of the passive previous transfusion. That
Yeah.
time titers will be very low. And apart from this, again advice from the hematologist will be required. But that usually the titers are low. They are not rising anymore.
You mean in case of if we give the patient at 28 and 34 weeks, we give them antibody, right? Prophylactic antibody.
Yes.
I mean,
Yes.
to compare this antibody, or it is due to the sensitizing antibody. You mean it depends on the lab titer? Never?
No, see, if the patient is already sensitized, if the patient has antibody already,
No,
then you will
no,
not give
prophylaxis.
prophylaxis.
Yeah. Will not give a prophylaxis. I mean, after that, or is there is
See,
no possibility?
if for any reason the patient has been given NTD prophylaxis, and when
Yeah,
you do testing and you find NTD has come positive,
yeah,
then to find out whether patient has got immunization, or whether
mm,
it is from passive transfusion, like previous antibody that we have given, the test is detecting that. In that
yeah.
situation, titers will be different. Titers will be very low if there had been previous antiglobulin given, and it
Okay,
will not rise also, it will be the same.
okay, yeah. I get the
Okay.
point. Thank you, doctor. Yeah.
Yeah. Okay, so what will happen if unknowingly RH positive blood has been given to RH negative mother? Now if it is less than 15 ml, then IM antibody can be given. But if it is more than 15 ml, then a larger amount of NTD would be given. In that situation, either it will be 1500 or 2500 international units, and this much amount cannot be given IM, so it will be given IV. Now there could be another scenario: whole 1 unit of positive blood transfused to RH negative patient. What you will do in that situation? Answer would be exchange transfusion. Red cell exchange transfusion has to be done. And if the exchange transfusion done one time, it will be successful in 65 to 70% reduction of a D positive cell. But if it is done like 2 times, then it will be, or if it is doubled, then it will remove 85 to 90% of RH positive cells. You will get question from every part of this slide. Okay, this is the situation when unknowingly or by mistake inadvertently RH positive blood has been given to RH negative mother. So this will be sort of management. Now this part I have already explained, that it is not like NTD you can give just explaining the patient, There should be complete like a check of the antibody like batch and expiry date and all complete information. Patient also should get verbal information and written information, and the patient has to be consent has to be taken, then only this entity to be given. Okay, and because entity is a human product. Okay, it is a human product, and if the patient is sort of a Jehovah Witness, they may refuse it also. So whatever, well, whether they will accept or they will decline should be clearly documented in the notes. This is all about the documentation. So that's all I had to say about NTD guideline. So anyone have got any question, or should I go ahead? This is the last guideline. This will be like a very small briefing. Any question till now? Okay, so you will get question from this in your exams. So detection of anemia in the pregnancy or diagnosis of anemia. First trimester, if the hemoglobin is less than 11. Second and third trimester, if it is less than 10.5. And postpartum, if it is less than 10, then this would be considered as a diagnosis of anemia in pregnancy. You get question from this in your SBA's EMQs. Apart from this, like usually first will be the treatment will be the trial of oral iron. But if there is and say whether the patient is taking it or not, so compliance and and further test to be done after 2 weeks. If there is no demonstrate, we are not able to demonstrate the increase in the hemoglobin. Usually the screening is done at booking in 28 weeks. This I have spoken many times, that they do hemoglobin grouping and typing and antibody testing at booking and the booking visit and at 20 weeks also. This you will find in your NICE 2 in guideline, that if the patient has multiple pregnancy, then they are doing FBC one more time. That is anywhere in between 20 to 24 weeks of pregnancy, because we know that in pregnancy chances of anemia is quite high. Now this what could be the treatment? Everybody knows it. So it will be oral iron first line. But if the oral iron is not tolerated, or if the time is less, like patient is about to deliver, consideration for parenteral iron is required. Apart from this, any woman having like renal and stage renal anemia, in that situation hemopoietin, human erythropoietin to be given. But yes, this has to be given with an expert hematologist advice only. And what they say, that active management for third stage of labor is recommended. That would cause minimize the blood loss. And with the antenatal use of iron with or without folic acid, 50% risk of anemia reduction in third trimester of pregnancy or delivery. So you may get question from this line also. So this number is from your guideline. Now like what they say, that grouping and blood group and antibody status check should be done at booking in 28 weeks. They are repeating same thing in every guideline every time. And group and screen sample, if we have to like do the group and save for any patient, the sample should not be 3 days old. But if any other patient is there, then where there is a high risk of transfusion, in that situation group and save screen sample should be sent once a week. So they have to because they want to know whether there is a development of any new antibodies there, so that they can keep blood available accordingly to the requirement of the patient. Now blood transfusion in the pregnancy, this I have spoken previously also. So ideally it would be like matched with ABO, RS typing, K negative and CMV negative. So these are the requirements for the ideal blood transfusion in the pregnancy. But if the clinically significant antibodies are there, then blood negative for that particular antigen to be cross matched. Otherwise, we know there would be a hemolysis reaction. Now the cell salvage, the same thing again, but the guideline what the guidelines say, cell salvage is done if the anticipated blood loss is more than 20% of the estimated blood volume. So this, you may get a question from this number. Apart from this, if the ICU, if cell salvage is done, then this same thing again they are repeating, that 1500 international NTD to be given, and also we'll do the test for the FMH within 30 to 45 minutes of this process. It is the same what we are reading from the NTD guideline, but yes, it was there in the guide in your blood transfusion guideline, so I put again. Now blood transfusion will always be required if the hemoglobin is less than 6. Why it is important? Otherwise there would be heart failure. Okay, and it is rarely required if the hemoglobin is more than 10. Okay, this number would be important because you may get SBA from here. In the emergency extreme situation, consideration for O negative blood cells can be done. Okay. Now for the FFP, again FFP, if it is given what about this FFP in blood transfusion guideline, APH guideline and PPH guideline, some small differences there. So I have put everything to create to clear that all doubt. So FFP, if there had been bleeding and the 6 units of red blood cells has been given, then for any MOH or major obstetric hemorrhage, FFP to be given at the dose of 12 to 15 ml per kilogram. Okay, and what we want to achieve is APTT, and the PT should be less than 1.5 times from the normal. Okay, so basically I want to tell you this, that if for every 6 are red blood cells, they want 12 to 15 FFP to be given for at the dose of 12 to 15 ml per kilogram. Now platelet transfusion, what is a trick aim of the platelet count to maintain platelet count will be above 50. Okay, so they would want a platelet count to be above 50 in acutely bleeding patient, and trigger to transfusion is 75, that so that we can provide that margin of safety. And RHD negative women should receive RHD negative the platelet, because we have already read that if RH negative person is getting RS positive platelet, then NTD injection has to be given. Now, in the life-threatening PPH, at the last resort, recombinant factor 7A can be given. Now, intrapartum and postnatal blood transfusion less than 7 in labor or immediate postpartum, less than 7. So, in pregnancy, they are saying less than 6 blood transfusion, but intrapartum postnatal blood transfusion, they are recommending more than less than 7 grams of or 70 gram per liter. Now patient who declines blood or the Jehovah's Witness, so ideally what we should do, there should be optimization of hemoglobin and there should be documentation. So advance directive is in document where what the patient will accept or what the patient will refuse, or everything is documented. So advance directive would be there, and all other methods to be there, so that all pharmacological or mechanical and surgical procedure should be like that, so that they should be done conservatively, so that less bleeding or would be there, and because the patient will not accept blood. Consideration for cell salvage could be done for the autologous transfusion. If the patient will not accept any other person's blood, so consideration for cell salvage or consideration for autologous transfusion can be done. Now a little few knowledge about this, because the question I have seen from here also. So what is FFP? So FFP is fresh frozen plasma. It contains physiological range of all clotting factors. So fibrinogen is there, 400 to 900 milligram per unit. Plasma protein, usually albumin, and physiologic anticoagulants, protein C, S, antithrombin, and added anticoagulants. And because of the storage purposes, factor 8 would be less. Factor 8 would be less if we compare to the normal plasma, that by 15 to 20%. And shelf life of FFP, if it is stored -18 or lower, it will be 1 year. Okay. So many times you will find certain questions, and the people have sent me query as well. So usually the answer will come if you know the contents of the FFP well. Now another is cryoprecipitate. So cryoprecipitate is also called as cryoprecipitated antihemophilic factor, because apart from this, it is made usually by thawing FFP at 1 to 6 degree Celsius. And like cryoprecipitate contain fibrinogen, fibronectin, factor 8, and von Willebrand factor, and factor 13. So it is like more amount that it contains is the fibrinogen and factor 8. Because of that, we are calling this antihemophilic factor also. Again, it can be if the criteria is followed, cryoprecipitate can be stored for also 1 year. Cross matching is not done for cryoprecipitate. So cryoprecipitate cross matching is not necessary. All ABO group are acceptable for transfusion to all type of ABO types. So cryoprecipitate can be given without any like sort of a cross matching. So this component you should know, because sometime some question you will find. Now, what is the difference in these three guidelines? In antepartum guideline, it is your green top 63. If they are giving like 6 unit of blood, they are giving 4 unit of fresh frozen plasma. So 6 unit of RBC and 4 unit of fresh frozen plasma. And apart from this, while they are waiting for result, 10 units of cryoprecipitate or 2 packs. So usually 1 pack will have 5 unit of cryoprecipitate. So this is given empirically. So this is antenatal guideline, and there is difference in the PPH guideline. In PPH guideline, what they say, for every 4 for every 4 unit of RBCs, they are giving 4 unit of FFP, and 2 of cryoprecipitate they would be given. So this part is same. So they are giving 2 packs or 2 pools of cryoprecipitate. But in antepartum guideline, they say 6 RBC, and for every 6 RBC there is 4 units of FFP. In postnatal, they are saying 4 RBC and 4 FFP. So this creates confusion. So better idea, you see the question from where it is coming. If it is if it is antenatal patient, follow antenatal guideline. If it is postnatal, follow postnatal. That's it. So this is the difference that creates the confusion. And in your blood transfusion guideline, again, for 6 unit, they are not giving any 6 or 4, they are giving the dose. Even here also they are giving the dose. In here also they are giving the dose, and even here also they are giving the dose. So if you consider FFP according to the dose, that is 15 to 12 to 15 ml. If you consider according to the dose, then dose is same, okay, all scenarios. But if you consider according to the units, then antenatal it is 6 RBC and 4 FFP, postnatal it is 4 RBC and 4 FFP. So this is the difference that you should be aware of. That's all about this your blood transfusion guideline also. So that's all I had to say. Now there would be some questions for more learning. So anyone have got any question till now? Or otherwise now you will you can just tell me the questions. Anyone any question? Okay, no question. Fine. So a 28-year-old woman in the second pregnancy and 14 weeks of gestation, NTK is 1 in 16. So again they have given the titer for K. Okay, what should be done? So immediate blood test for K antigen, maternal blood testing for K antigen after 20 weeks, measure titer every 2 weeks, every 4 weeks, or paternal blood testing for uh, genotyping K antigen.
Paternal blood test for genotyping for K antigen.
Let me see.
B.
Yes. So first step would be testing maternal test. Yes, answer is B, maternal blood test for fetal genotype K antigen after 20 weeks of gestation. So for any potentially sensitizing event, non-sensitized women should receive 500 international unit within 72 hours, and regardless of the NTD prophylaxis, for any additional dose guided by the test of maternal blood. So what is the dose calculation formula?
It's B, ma'am.
Yes, it is B. It is 125 for IM, 100 for IV. The 30-year-old woman with previous cesarean section, multiple for fibroid and breach, she has massive PPH and blood loss of 3 liters, and she has a Rh negative. I had a transfusion of group specific blood cells, reinfusion of cell from cell saver, and FFP precipitated platelets. Cord blood is confirmed Rh negative. So NTD prophylaxis is administered if she had a following of the blood products transfused.
C, ma'am.
Yes, it is C. So we already know that if the Rh positive platelets are given, so for 5 adult dose, um, 250 international unit to be given. So 29-year-old woman in antenatal clinic in the second pregnancy, 24 weeks. Current pregnancy, she has irregular antibodies detected with a booked blood test. Ultrasound scan at 20 weeks reported low-lying placenta, multiple episodes of bleeding. What statement should be true regarding antibodies? So blood sample for cross matching to be taken every 2 weeks. We know it is 1 week. C and both C and E are detected presence of anti-B increases severity of fetal anemia. Serial monitoring for anti-K antibody recommended, and referral when the levels are more than 4. For anti-K, there are no levels, for invasive testing, maternal blood shows baby K negative. Weekly ultrasound for hemolytic disease is done. No, fetal, it is not done. It is 1 to 2 weekly. Referral to FMU when the NTD reaches 15. No, once the NTD reaches 4, we are referring them to fetal medicine unit. So what would be the answer?
B, ma'am.
B, yes. B would be the answer, because if the C and E together, then it increases severity of anemia. So this is an EMQ. So 20-year-old woman in the Cambridge University, she wants to terminate the pregnancy. She had vaginal bleed 1 week ago, requested attended EPU at local hospital. She saw there is a USG shows single viable pregnancy of 11 weeks. GP refers clinic for termination of pregnancy. She goes termination. 2 weeks later, and her blood test received that she is Rh negative. and positive for the NTD and RSD antigen. So what should be done?
No, not recommended.
Yes, the patient has already NTD. She's already immunized, so NTD is not required. 20-year-old woman attended with a mild vaginal bleed. Urine pregnancy test is positive. Ultrasound scan shows 5 weeks pregnancy. Her blood group is AB negative, and she has anti-KL antibody.
And once please show the previous question.
Hmm?
Once please show the previous question, ma'am.
This is the previous question.
No, this okay. Here, single viable pregnancy of 11 weeks. GP refers and she goes after 2 weeks. That means it's at 13 weeks she had termination. Ma'am.
Yeah, but she is already immunized. She has an Rh anti-D antibodies. So at whatever the stage she goes for termination, anti-D will not be required because she's already sensitized. Is it clear?
Yes, ma'am.
Hello, is it clear?
Yes,
Why
ma'am. Yes,
anti-D?
ma'am. I missed that. Yeah.
Okay, so answer to this question.
Recommended you.
Yes. No no answer.
Yeah.
Same I,
recommended.
ma'am.
Same I. Yes. Because if she is 5 weeks of pregnancy, what you will do now? Mild vaginal bleed, you will do nothing. Okay. She would require anti-D prophylaxis. So 20-year-old woman attended at 21 weeks with a mild vaginal bleed. Obstetric USG shows fetal of 22 weeks, low-lying placenta. Her booking blood shows O blood group, no antibodies. What to be done? "21 weeks, what you will do?"
Ma'am, 500 units, ma'am. To be followed by FMH, ma'am.
Yes, but that option is not there. FMH is not there, so answer will be anti-D 500. Okay, 20-year-old woman attend
Ma'am, do we need NTD in minimal vaginal bleeding?
Yes, you need after 12 weeks. In less than 12
Okay.
weeks, you don't need. Here the patient is 21 weeks, so you will need.
Okay, ma'am. Thank you.
So 20 years old woman attended APU at 8 weeks, complains of mild pain, mild bleeding, scan shows left ectopic pregnancy, no free fluid, she's stable, fine, appropriate, she goes for surgical management. So what to be done?
D, ma'am. 250 units.
250, yes. So less than 20 weeks, 250 is the answer. So 20 week,
There are antibody to Duffy antigen.
these are Duffy antigen is different antigen, and that is just to make you distract from the answer. So if they say she has got antibody to D antigen,
Yeah, yeah.
okay, then you will say she is immunized. But
Yeah,
Duffy makes no sense. Yes.
subminor subgroup. Yeah.
Yeah, this is distractor. Okay, so the patient is obstetric, 36 weeks, antepartum hemorrhage. She received NTD at 32 weeks. Okay, her blood group is O negative, os closed. USG shows viable pregnancy of 36 weeks. So what you will do? Antepartum hemorrhage 36 weeks, what you will do?
E, ma'am. Anti-D. 500 units.
500. Yes, 500. Okay, 28-year-old woman in first pregnancy, fetal loss at 21 weeks. Answer?
E, ma'am.
Yes. Oh God. Yes. So more than 20 weeks, NTD 500 and test, FMS test. So answer is B. RH negative pregnancy with threatened miscarriage at 14 weeks of pregnancy. NTD administered. But she again started bleeding. So what you will do?
Ma'am, F, ma'am.
Yes. So NTD
E.
at every 6 weeks. So 39-year-old woman in third pregnancy. She wished to be sterilized and after birth and declines NTD prophylaxis.
E, ma'am.
Hmm? E. No NTD required. Yes, but before that, you have to check NTD screen at 28 weeks. You have to check whether the antibodies are there or not first. Okay. So check screen and booking NTD whether she is sensitized. Okay, they have given non-sensitized.
Okay, ma'am.
They have already given non-sensitized. So ideally, like answer should be respect her wishes. Answer should be respect her wishes. More to be added, in my opinion, it should be respect her wishes, patient autonomy, but that option is not there. Respect her autonomy, like no NTD required, we cannot say the right answer because ideally NTD to be given only, but the
Yes,
patient
ma'am.
is refusing. So
Mm-hmm.
answer should be respect her wishes, but that option is not there, and they have not given week. So because of that, book writes this answer. But ideally, to be respect patient wish should be answer. Okay, NTD negative woman received 30 ml of blood before discovering that she has been giving RH positive blood. What you will do? So it is inadvertent blood RH positive blood transfusion. Yes, so you have to give 1500 or like uh, a large amount has to be given. 1500 or 2500 IU. So the G is the answer. Large dose. Okay. So the 35-year-old woman pregnant for third time. First child is a 5-year-old and is positive. Second pregnancy, she's immunized and lost her baby to hydrops fetalis. After that, she has divorced. She's remarried, third time pregnant, and her test is positive. She has come for further advice. What to be done?
Ma'am, paternal blood group and RH typing, ma'am.
Yes, ideally this should be the answer, but it is not. Ideally, paternal blood group to be tested first, because if the father is negative, then there would be no issues. This should be the paternal blood group and rhesus typing should be the answer. Okay, the patient is 36 weeks pregnant. She undergoes ECV for breech. She's RH negative, non-sensitized. 2 injection has already been given. So what you will do now?
D, ma'am.
Yes, D, because the ECV is a sensitizing event. Now, 19-year-old have anti-K antibodies. She conceived when she was on holidays, no contact with the father. What to do? So father testing cannot be done. So what you will do? Baby testing, yes, FFDN. Okay, as a 41-year-old woman with multiple anomalies, routine 20-week scan, amniocentesis performed 13 weeks, and trisomy 13 is diagnosed. After counseling, she opts medical termination. So test confirms that maternal hemorrhage of 4 ml. What is the dose of immunoglobulin?
500 international.
Yes, it is
Ma'am,
500.
2, yes, ma'am. 500 units.
Yes. So a 31-year-old homeless patient, heroin user, unknown of dates, found to be approximately 28 weeks of gestation on ultrasound. She is also found to be RH negative, receives anti-D at 30, according to the prophylaxis, after one week after her injection. At 30 weeks, she had small postcoital bleeding, but the cervix is closed and placenta is not low-lying. So there is no cervical cause, and there is no placenta previa. So what will be the answer?
And then routine is 34 weeks as planned. 2 months.
Hmm?
2
2,
anti-D
ma'am.
500 now, CLIVA test, and then routine at 34 weeks as planned.
Yes. So this is a sensitizing event, APS possibility of abruption. Okay, so now you have been asked to review 31-year-old Nalipara who is 12 weeks, fit and healthy, has a past management for miscarriage 10 weeks. Her booking blood shown A negative and anti-D is 3. What to be done?
Surgical management 250 international units IM.
Hmm?
250 international units IM.
The patient is already sensitized. Patient has anti-D present.
I measure serum antibody levels every 4 weeks.
Yes. So it is like if anti-D is more than 4, we refer them to fetal medicine unit, but it is 3. So 4 weekly testing to be done. Okay, till 28 weeks. Okay, so patient is 29 weeks pregnant, referred to antenatal unit for symphysia. This is like very good question, and this is from strategy, and people do make mistake. They will see the entity positive and they will think of alloimmunization and they will say not required, no action required, but actually it is not. Okay, so this is very important learning question. So if the NTD they have given, yes, the patient is immunized, so patient is at risk. So what we have to give? The thing if the levels are given, then we have to, if it is less than 4, it is 4 weekly till 28 weeks, then it is 2 weekly. Okay. and once it is more than 4, refer to FMU. So now the patient is 29 weeks, refer to the antenatal clinic for large for date. In previous pregnancy, she has antepartum hemorrhage, normal delivery at 37 weeks, baby girl weighing 2.9, progress to expected dating. Normally scans shows no anomaly. Booking, she noted elevated NTD level. And 16 weeks level was 3, 20 weeks level became 4. She missed her 24-week appointment. Ultrasound now shows polyhydramnios ascites edema. NTD has come up to 18. What to be done?
Refer to fetal medicine. Refer to fetal medicine.
Yes, you have to now, the patient is already hydrops, refer to the fetal medicine unit. Okay, so 27-year-old woman for ECV at 38 weeks and like blood at USG confirmed single baby, flex breech, BMI is 26, blood group O negative. She received routine NTD. What to be done at 28 weeks now?
500 international units IM antibody.
Yes, so this is sensitizing event, give 500 international units. So 22-year-old primey with a 34 weeks of pregnancy in the antenatal clinic. She's RH negative with RH positive baby. She attended a hospital 1 week ago, the antepartum hemorrhage. Did not receive NTD. What to do?
100 international units.
Yes?
IM.
You still administer.
Yes, ma'am. You can give, ma'am, up to 10 days.
Yes, you can. The effect will be less, but you can still give. Okay, so 34-year RH negative woman at 22 weeks of gestation. She has received. She has completed platelet transfusion for allo immunization to platelet. What to be done? Yeah, so she would require NTD. Okay, yes, you are right. NTD intramuscular. So RH negative. I think this would be the last question. So 31-year-old woman with 16 weeks of pregnancy. For her booking blood, she was found to be RH negative, anti-C antibodies. Anti-C level is 5. What to be done?
Measure antibody levels every 4 weeks.
Yes, because it is less than 7.5. So we measure it every 4 weeks. That's all about it. So like this time there would be live circuit for MRCOG 3 in Delhi. So the date is 15th October. So thanks for joining. Any one of you have got any question can ask. Anyone any question? Okay, all the best people. Thanks for joining.
Thank you, ma'am.
Welcome.
Thank you, ma'am.